Good afternoon, everyone. While we prepare for the slides, I think we are at the cusp where obviously the immunotherapy are making a stride into the early stage lung cancers, and that's where we are. What I'm going to do is I'm going to obviously talk about the IMpower010, but I'm also going to give you a brief about what are the options which are there. I think we as oncologists are divided between the new adjuvant space and the adjuvant space, and that's where the conundrum is going to lie, whether we're going to do the immunotherapy in the adjuvant or new adjuvant space. So coming to the IMpower010, and the slides have been given by Roche. They've been excellent prepared set. So basically, it was a phase 3 multi-center open-label trial in which the placebo was not given. The patients were kept on observation. The reason for that is the company felt it was unfair to call patients every 3 weeks to give a placebo. So it was basically an open-label trial in which the patients from stage 1B to stage 3A were taken. The tumor size was more than 4 centimeter. The patient were given, so they all had a R0 resection. Post R0 resection, they had undergone 4 platinum-based chemotherapies, and after that, they were randomized 1 to 4 therapies, and they were randomized to atezo versus observation or the best supportive care. They were stratified according to the histologies, the stages 1B, 2, and 3A, and the PDL1. So the platform in which they did a PDL1 was SP142 to begin with. But however, they realized that non-small cell is it's tricky when it comes to the PDL1s, and they moved on to the SP263 by the time they presented the results. So the primary endpoint was the disease-free survival, and the secondary endpoint, disease-free survival in stages 2 and 3A and the ITT population. And the key secondary endpoints were overall survival, the disease-free survival in PDL1 more than 50%, and the 3-year DFS and 3-year and 5-year DFS. So it's a complicated trial because it's something which was new. So they obviously wanted to go step by step. So the first step of the statistical analysis was they wanted to start with the DFS in the PDL1 positive population. If it's positive, they would want to move on to the DFS in the entire population, which is stage 2 and 3A. If that is positive, they wanted to move down further to DFS in ITT population, and then OFS or OS in ITT population. The characteristics were well matched. As we generally see, the non-squamous NSCLC was slightly more in proportion. They did include patients who were EGFR and ALK mutated. However, they were a very small proportion. And almost 50-55% patients were the PDL1 positive. So what was seen in the results were that at the first step of analysis, the DFS in the PDL1 positive population in the stage 2 and 3A, it met its primary endpoint. There was an improvement in the disease-free survival, and this is where the curves are showing. At the end of 2 years, the difference in the disease-free survival is somewhere in the range of around 13%, 13 to 14%. At the end of 2 years, around 75% patients were disease-free in the atezo arm versus 61 in the best supportive care arm. At the end of 3 years, it was somewhere in the range of 60 and 48. I think the gap was maintained, but obviously, as we went along, the proportion of patients fell down. So if you look at the subgroup analysis, what was interesting to note was that patient who there was obviously a benefit seen in the EGFR, but I think we should not be taking that from this because the proportion was very small. So in EGFR mutation in ALK rearrangement patients, the value of this trial probably would be questionable. Otherwise, I think in most of the subgroups there was a trend towards atezo benefit. Coming to the second step of the statistical analysis, there was a DFS in the entire population of stage 2 and 3A. Again, there was a benefit seen, however, not to the category of what was seen in the PDL1 positive population. The difference was in the range of more like 11 to 12%. If you look at the subgroup there, it's interesting to note that the difference or the benefit which atezo is providing possibly is being driven by the PDL1 positive population and specifically by the PDL1 population, which is more than 50%. So it's fair to say that, at the end of this trial, possibly in a person who's SP263, PDL1 50%, more than 50%, I think that's where this drug will possibly fall in. Other than that, I think so. This, if you look at the PDL1, this is what I was trying to tell. That if you look at the forest plot there, a huge amount of benefit comes from the population which is PDL1 more than 50%, and then the benefit is lesser in 1 to 49%, and it's hardly there in the PDL1 less than 1%. So again coming back to the point, then the proportion of the benefit which is being driven is possibly being driven by the PDL1 positive population. In the DFS with ITT population, the benefit is, one second. So we do not have a end result there, possibly because the stage ones are, it takes them longer to show a relapse. And I think till today, the benefit is not there in the DFS in the stage 1A, 1B population. This benefit is still restricted to the stage 2 and 3As. In the overall survival, I don't think we are there yet. The data is still immature. The number of events which are supposed to happen have not happened. And, this is where we are. The median OS is not reached. However, numerically, the number of events are lesser in the Atezo arm, but then, it's anybody's guess where this will go. Again, I think it's the same thing. The OS, we are not there yet as yet. So in this also, the benefit has possibly been driven by the 50%, PD-L1s more than 50%, and that's where we are. In the EGFR ALK mutation positive, I possibly think that these numbers are too small for us to make any inference out of it. Coming to the toxicity, almost 90% of the patients, they did have some degree of toxicity. Almost 30% of the patients did have some degree of severe toxicity, and around 20% they had hospitalizations because of it. So the majority of the adverse effects were hepatotoxicity and pulmonary toxicity. That's where the majority of the adverse effects were. So to conclude, basically it's a first phase 3 trial we have in adjuvant. We have a lot of trials coming in after this. There are trials with Nivos, there are trials with Pembros and Durvas. This is the first trial on the block which has definitely proven that there is a DFS advantage when you give a year of atezolizumab to somebody who's been treated with surgery followed by adjuvant chemotherapy. There is a DFS benefit in the patients who are PD-L1 positive, and primarily there's a huge benefit in the patients which are more than 50% positive. So this is what has been reflected in the guidelines also. It's almost made, it has almost recommended in every guideline now. So I think just the last slide, anyway, the last slide, it's not being put there, but what I wanted to say is in the neoadjuvant space and adjuvant space, so when we look at the immunotherapy in the neoadjuvant space, the benefit there is that it's a limited number of cycles. You still have the tumor intact, which is possibly causing the immune milieu there, which is making the immunotherapy act more. In an adjuvant space, we do not know where we are. We do not have an endpoint. In neoadjuvant, we have a PCR to know that there is a benefit there. In an adjuvant, you possibly have to wait for the longer term to get an answer there. So that's from my side. Thank you.